It's my great pleasure to introduce David Butt, who's travelled all the way from Canberra to come and talk to us today about a really important topic, which is policy and how policy is formed and what influence we might have over policy in the broader scheme of things. Many of you know David as the reasonably newly appointed CEO of the National Rural Health Alliance, but he was also the former CEO of the National Mental Health Commission and previously involved with Rural and Regional Health Australia. So I'd like to ask David to come up and talk to us about policy.
Thanks, Rose, and thank all of you. And can I begin by acknowledging the traditional owners of the land on which we're meeting today and pay my respect to elders past and present. And can I also acknowledge all of you? I mean, it's been really very enjoyable being here today and learning much more about what's happening across New South Wales, and really also seeing the level of engagement that's occurring among you all, and lots of good chatter going on, so that's great. I will talk about policy development such as it is. I guess I'll say a little bit first about the National Rural Health Alliance. Some of you would know us pretty well. Some of you are members engaged with us through member organisations and the like. We're the national peak organisation, an alliance of 38 peak national rural health organisations across the country. Broad membership, including consumers, so Country Women's Association of Australia, Isolated Children's Parents Association, peak Aboriginal groups, Aboriginal and Torres Strait Islander groups, including NACCHO, and the peak groups representing doctors, nurses, allied health professionals and Aboriginal health workers, whole range of service providers, Royal Flying Doctor Service, workforce agencies, including Rural Health Workforce Australia, and therefore covering also that, which includes RWN. And yeah, a range of organisations, basically covering about 250,000 individuals and another 450 member organisations spread across the country, and so therefore has a lot of reach. But as Rose was touching upon, one of the issues that we need to grapple with as an organisation is how we use the effectiveness of that network to influence the agenda, because that's what the Alliance is about. How do we lead, unite and harness the sector's capacity and intelligence to drive policy changes, which ultimately are about helping the health and well-being, improving the health and well-being, and reducing the divide between rural and remote health and that of metropolitan health for 7 million people who live outside metropolitan and inner regional Australia. So, and that we have a diverse membership. Phil and I were just talking about there's strength in our diversity. There's also challenges because of the diversity and the broad agenda that comes with all those different members. But when you think about, if you're focused on the end point, which is about the health and well-being of the community, which I know you all are, there's a really common purpose there, and that's very important when you start talking about policy development and driving policy change. So our approach really is about how do we harness that collective ability, the collective impact of our members and the people that they deal with, the lives that they touch across the country. In terms of policy priorities, I'll talk a bit about ours, and that's come through work with our members over a substantial period of time, but your policy directions really reflect the environment within which you're operating. And I'll talk a bit about government and how do you try and bring the two together. Ours, priority number one, and it came out of the National Rural Health Conference as well in Cairns recently that I was talking about a little while ago, is about getting a new national rural and remote health strategy and associated implementation plan with a long-term investment agenda. We've had national rural health strategies plans in Australia from 1994 right up until 2011, and we are now in this strange period where there is none. And I think that is reflective of what's happened with rural and remote health in terms of the national agenda. We've seen a lot of things, and it's a lot to do with things that have happened with COAG structures and other structures at national levels. We've seen a lot of things swept up in broad agendas, and often those broader agendas are driven by, not surprisingly, metropolitan interests. So we think it's very important that there be that key focus through a national rural and remote health strategy and plan on the health and well-being of the Australian community outside those metropolitan, inner metropolitan areas. So that's a big agenda for us. A lot of the other areas, I think, were not surprising. You know, Aboriginal and Torres Strait Islander health and social and emotional well-being, workforce. We go into that, models of care, all sorts of things that we're looking at. How do you integrate evidence, teaching and the likes? A strong focus on primary health networks and how we can work in place-based approaches in coming up with local solutions, because it's local communities that really know what solutions are required at a local level. And I often say that it's the further you are away from a problem, the less likely you are to have the solutions to that problem. It's actually about local and place-based approaches, and that inevitably involves the community, not just one particular profession. It's about community approaches to how you respond to things. One of the areas, though, that I think that we need to do is to focus more on the economics of rural and remote Australia. And we know rural Australia is a powerhouse in driving the Australian economy, has been for a long, long time. And yet I think while we recognise a lot the challenges of rural and remote Australia and also the great advantages, we focus a lot on the social side of things, on the impact on individuals and families, but probably don't identify well enough the economic impact of in fact, closing that divide with metropolitan Australia. I mean, if we do the right investment, if we can look at long-term improvements in health and well-being, we not only improve the health outcomes for individuals, improve it for families, and for communities, but we actually increase productivity, we enable economic growth. So it's about looking at, and that comes through greater participation in the workforce, greater participation in the education system, getting higher levels of education, the jobs that would flow to rural and remote Australia, if we unlock that potential, because we know there's a big gap at the moment. The health outcomes in rural and remote Australia are obviously far worse. Employment levels are lower, incomes are lower. There's a whole range of factors that are holding back the economy, and we could make a difference there. And I think when you're dealing with government, trying to demonstrate the economic benefits of investment is a really important thing, but I'll come back to that as well. And then a whole range of other things that we're looking at in terms of mental health, suicide prevention. We all know about the statistics in those areas in terms of the differential outcomes. Population health specific issues, but also looking at some areas like early childhood development and the flow-on effect of building strong families, resilience from a very, very young age. Government policy position, I suppose it'd surprise you to know that government policy development doesn't always follow a rational pathway. Highly dependent on political circumstance, highly dependent on what they're trying to achieve. And often a government political agenda could be something as simple as we want to keep health off the front page. And that's a pretty big driver in politics. It's a reality we have to deal with. The good thing is, in fact, successive Australian populations, and it not matter whether you're talking federal or state or local, have very much kept health at the top of the agenda in terms of politics, and that's actually been a terrific thing. So we actually have seen change, albeit a lot of it's been piecemeal, and I think recent budget we saw some interesting turnaround, and we've got a minister who very thankfully has talked about a long-term investment, a long-term health plan, which is very promising. But we had a budget where the initiatives were very much about how to undo a lot of the things that were going to be put in place from the 2014 budget, like the Medicare freeze and so forth. There was also some money for psychosocial support related to NDIS and people who are going to fall outside the NDIS, and I think that was a very welcome thing. The Minister also talked about 3 waves of reforms, and a lot of those are about the big ticket items. They are about NDIS, they are about Medicare, they're about hospitals, all the areas that we know very well. There was a bit about the only mention of rural, strengthening mental health, particularly in rural areas, and that's for the second wave, and I think that's great. Focus on workforce, so there's going to be studies done into workforce, although I would come back and say we shouldn't really be looking at workforce in isolation. We should be looking at it within an overall context of a strategy, again, about all the things that contribute to health and well-being, and that should be about models of care. It should be about other infrastructure. It should be about funding arrangements. It should be about a whole range of things that should be taken into account in relation to an overarching strategy on health and wellbeing. And the other area that was highlighted was aged care, and that's also a good thing because we know, of course, significant challenges in aged care in rural Australia and particularly remote Australia, and probably going to be compounded by the NDIS because we're going to be seeing NDIS providers basically dealing with similar workforces as you do in aged care, and potentially there will be a significant workforce gap there. And then moving on in the third wave onto hospitals again, which shouldn't surprise anyone. Primary health care, prevention, and particular focus on Indigenous health. Now, what I wanted to do pretty quickly was to really do a quick assessment of the environment because strategy, as I say, very relevant to environment, and I'm going to use a quick pestle model, which is a tool you use to look at your external market when you're looking at marketing strategies, and that's pestle: political, economic, social, technological, environmental and legal. And if I start with the political, we are actually in a very unstable political environment, as we know, and it doesn't matter whether you're dealing nationally or at a state level or indeed internationally. I mean, we've got huge instability, and that drives government agendas, it drives the timeframes in which they're trying to get things achieved, very short focus often in those timeframes. So it's very hard to have a long-term strategy. I mean, I talked about the things that are priorities for the National Rural Health Alliance. They're priority areas, but what you actually need to look at then is what are the on-the-ground things that you want to change? What are the things that you're wanting governments to commit to in 12 months' time, which are going to contribute to what you do in 2 years' time and provides the flat platform for where you want to be in 10 years' time. So you need to be able to give government short-term wins. I mean, they like being patted on the back, basically, instead of being kicked in the bum. And that's something that I think is always worth remembering. So it is about trying to identify things that are going to be attractive to them in the political cycle, but which build up to a longer-term agenda about reform across their whole Australian health system. The big focus very much in the budget, again, on reducing deficits, major items of health. The federal-state vertical fiscal imbalance problems are not going to go away. Financial pressure is going to be on the states in relation to the ability to afford, even though they keep on pouring more money into hospitals and yet we don't have an integrated system. I think I know the move to primary health networks has been very much about how do you bridge the divide between what happens at a national level and what happens at a state level, because we've never been able to close that particular problem about the different divide between Commonwealth and state and issues of blame shifting and cost shifting. And so one of the ideas underpinning the reforms of primary health care, from divisions to Medicare locals to PHNs, has been very much about how do you get away from that political level and move to meso-level organisations that can work together, as in LHDs and PHNs, to come together to develop integrated models of care, shared population health planning, needs assessment, commissioning of services and delivery of services on the ground. PHNs working under very restrictive arrangements at the moment, but hopefully they'll get more flexibility over time as they demonstrate their value. But it does create an opportunity that we haven't seen in the Australian health system for a long time. Their fundamental focus is about building capacity and capability and bringing those systems together, but that will take some time to get to. And one of the things that, of course, is happening under the federal changes is looking at new models of care, new funding models, healthcare homes, those sort of things, and that's a sort of a toe in the water. That I think one of the good things about it, and it was touched on earlier, that one of the problems that has beset the Australian health system is this focus on fee-for-service. And I'd say the other one that's beset the Australian health system I've touched on is the Commonwealth-state divide. So, we run into these issues about things that not only drive disagreements at a national level and a state level, but they do stifle innovation, and they do, in fact, drive siloing of the system. They don't bring the system together. So our funding models are wrong, our accountability, responsibility arrangements are wrong, and that's the long-term reform agenda, has to be moving away from those to get things that are focused on integrating, not disintegrating. So economic, Same thing, global economy, Australian economy unstable. We've got low growth, hence that focusing on funding versus investment, and that's where I started on the focus on economics, that we need the economic evidence that investment is a good thing. However, the economic evidence says investment is a good thing in terms of increasing productivity and growth, as long as you take a long-term view. And the reality about the economic cycle is that at the moment governments are very focused on investment in health as a cost, not as a potential saving. So it is actually usually about investing to save, as long as you take that long-term view, but we don't have that long-term view. Problem of the issue of the economy. We've got low jobs growth, low jobs income growth, as we know, so the economy is somewhat, well, certainly for workers, it's somewhat stagnant. You often talk about health spending as being relatively price inelastic, but I think we are seeing evidence that as people look in their hip pockets and see what they've got to spend money on, in terms of, do I spend money on paying for food, paying for shelter, paying for my electricity bill, or do I spend it on another pharmaceutical with high out-of-pocket costs? What choice are they going to make? So I think we are, and do we pay for private health insurance, particularly in rural and remote Australia, where there's far less value, and in fact rural and remote Australia is cross-subsidising metropolitan Australia through private health insurance. So do we spend money on that, or do we spend it on those other things? And I think you're seeing some greater price elasticity in relation to healthcare because of that out-of-pocket impact. S for social, I've touched on consumerism, nothing about us without us, and I think we will see more and more of consumers driving the agenda, and that's a good thing. And I think if you're Aboriginal and Torres Strait Islander people, or people with lived experience in mental health, of course you should be driving the agenda there. We're going to see it in disabilities with the NDIS, where it's very much person-centred packages. You're seeing it more in a sense, with PHNs moving towards that, more of that model. We are doing a commissioning model, which are around the needs of individuals, not service providers. And I think there's a certain sense of fear and trepidation from providers about the fact that we are moving towards a more consumer-centred, consumer-driven system, but that is inevitable, and consumers are demanding that, and that's the way it should be. So we are going to be talking more about co-design, consumers being there when you're designing, when you're commissioning, purchasing, delivering, monitoring and evaluating services, and that's a really good move. It's just something that we need to recognise. And I'll touch on just there on the social side of things. We know the demographics. I think the issue of obesity is one that has just got such a huge both social and economic impact coming towards us, and the World Health Organization target, which Australia has signed up to in relation to obesity, is that it won't get any worse. There are no targets about reducing it. It's actually about saying, can we make sure it doesn't get any worse? So, not overly brave, but probably somewhat realistic. So, significant challenge for us there. Technology, the T, we've had a good discussion about that. Again, Phil and I were having this conversation about the conference in Cairns, and Jenny May, who many of you would know, presented a slide at one stage of a washing machine and two pipes coming down to it and a snake coming out of one of them, and the quote going with it was that Telehealth won't fix this. And I think that's something that we really need to remember. I think there is this sort of concern or this suggestion that digital technology is going to be a replacement for all sorts of things that won't any longer need to be going out to rural and remote Australia, whereas in fact we know it's an adjunct. It's going to be a great addition, not just in rural Australia, but also in metropolitan Australia, something that we should be more open to, and we should be encouraging. We are lagging behind because of some of the systems problems we have between Commonwealth and states and funding models. We shouldn't be depending on Medicare to fund it. We should be looking at other models, but we should be seeing it as a part of an overall plan of support, care and so forth for the community, not as a replacement. And I think there is that particular risk there. I do think too, though, one of the things, and this again has been touched on earlier, is the power of data. Who owns the data? How do you use it? How do you access it? we can use data now increasingly for population health approaches, albeit at the same time we can use it on individualised care, and we need to maximise that, and we need again to show the benefits of that. E for the environment, we just can talk climate. We've got enough issues now in relation to climate. I mean, you can talk about things like food security. That's not just a climate issue, that's often to do with income and access and what's affordable, and often it's not the nutritious food that's affordable in your lower income areas. I don't think we're going to be seeing governments tackling the big business on things like sugar and sugar taxes and so forth. So how do we actually deal with those sorts of issues? But if we have warming, I think the estimate of the increase in poverty, the 500 million more people will be in poverty by the year 2050, with the anticipated warming of the climate of 2%. And that was presented to the Wonka conference in Cairns while we were there. So I think major issues in relation to climate, and we'll be talking more and more about the impact of climate, particularly in Northern Australia. Final one, legal, legislative. I think the safety and quality agenda is an interesting one because you can face a situation where we will get tighter and tighter on what can be done in certain places, and that's obviously good in terms of safety and quality to an extent, but I just think it's one that we need to be very clear about. We should be demanding the same levels of safety and quality in rural and remote Australia as we do elsewhere. That doesn't mean we're going to get the same access to services, but there are issues that I think about what is the level of regulation we're going to have in future, and is that going to restrict access to services in rural and remote Australia? So I think that's one that we just need to be having a close eye on, because it has the potential to go the other way. Evidence-based research therefore comes very strongly into that one. How do we use evidence about what happens in practice? And I think we need to get better and better at taking what you do and translating that into evidence. And I think the Medical Research Future Fund gives us great potential in that area. So I think that's one we should all be looking at. How can we link what we're doing into what the Medical Research Futures Fund focuses on very much on health services research. It's not on biomedical research, so it's the health services side, and I think if we can provide the evidence about what's effective, that's really fantastic. So in summary, I think we definitely need a plan to reduce the divide between the city and the country, and we then need a strategy about how we execute that plan. Biggest thing dealing with politics is to speak with one voice. What's your shared agenda? What's the common voice you're going to put out there? I mean, you can argue among yourselves in this room, but when you go outside, you should be talking with one voice and giving politicians a clear message, because if you go to politicians and, 75% of people agree with something, but 25% don't, or 10%, the loudest voices will be the 10%. And the easiest thing for government to do in those circumstances is nothing. So to actually really influence an agenda, you do have to have common messages and a common voice. You've got to be able to demonstrate, I think, more and more translate evidence into practice, into policy, so that you can provide evidence to government about the effectiveness of what you're doing. You need to think about what are the levers and processes. You need to think about the quick wins. So it's all about how do you bring together a shared common interest which is focused on the needs of the Australian population and not on individual organisational needs, and speak with that one voice and convince government about the desire of change and what they will get out of it and what the community will get out of it. Because at the end of the day, all our members, all the people we deal with, they are all voters. Thank you.
Thank you so much, David. Any questions for David around policy?
I wanted to compliment the National Rural Health Alliance. I'm one of the councillors on the National Rural Health Alliance. I am there nominated by the Rural Optometry Group of Optometry Australia, and I've been on that group for about 8 years now, and it's one of the best run NGOs that you can imagine, and also very much fun to be part of. But I just wanted to say I'm an optometrist who does outreach in New South Wales. I just wanted to make the comment, David, that one of the things that the Alliance does is to take councillors to Parliament House every year, and we lobby the parliamentarians directly. And one of the messages I keep getting from parliamentarians is, please don't bring me problems, bring me solutions. So, and I think It seems to me that, if you want to actually get something done, it needs the research, it needs the answers, and it needs a well-prepared presentation. Is that
Yeah.
all I want to say?
Yeah, agree entirely, Phil. I mean, that's right. I mean, they know the problems. They get feedback on the problems all the time. It's very hard to make it a priority for them if you're not giving them the answers about this, and this is what you need to do about it. And you don't want to give them a list of 200 things. You want to say, well, that's why I'm saying you build it over time. You say, well, next year, if you want to tackle something about childhood poverty or something like that, you give them an answer about what they can do on a short term and where they can get, recognised for doing it. Build it up over time, so you build your platform, build it higher, all the rest of it. But yeah, you have to go with the problems are known. The answers are what they're looking for, and look, they're very open to them. Quite frankly, they're very eager to hear feedback about what's going to work. So, and one of the things you'd say about rural is it's not like it's a bipartisan issue. I mean, generally there's a strong recognition of need and the potential benefits, but and I think we can get generally get all sides of politics on side in relation to change, albeit you can't get them always to commit money together. But it's about coming to them and sharing those solutions, as you say.
I was just wondering if you could comment a bit more on the Medicare freeze. I know some of the analysis is that rural practices, and also, I guess there's more pressure on AMSs to self-fund using Medicare items, and in an AMS we have to bulk bill. Can you comment on a bit more on that and its impact over the next few years? The impact comes very soon for our services in terms of for rural clinics and AMSs.
Yeah, look, we haven't done any specific work on it, but I have seen the commentary. I actually thought they sold that one pretty well, given that, in fact, some of the freeze isn't lifted until 2020, by which stage a lot of things will have gone further and further backwards. So, yes, the pressure will continue to be on. So, and I couldn't say specifically, but I did get feedback that it'll be particularly hard in rural areas. So I really couldn't go into it any more than that, other than to say, look, there's still a long time before it's totally lifted. Yeah. So there is a focus in the Future Fund on, as I say, health services research, and NHMRC, by the way, is also, I don't think it's done it yet, but about to announce its Centres for Innovation in Rural Health, which will be based on universities. I mean, if you look at the statistics, the investment in research outside major centres is pretty poor. So the Futures Fund has actually identified rural as one of its priorities. So they have a strategic plan which identifies that. I think the way to do that would be really linking with some of the areas that have really good regional networks now, universities, departments of rural health and those sort of things, where I think there is potential to come up with innovative solutions that they want to invest in. So again, it'd be about having the capacity to demonstrate something on a scalable basis that is then, well, on a sufficient basis that you can demonstrate it potentially would be scalable more broadly. So I think that'd be the area where I'd go into it. The EDRHs have quite good expertise in the areas, so I think they're a good place to begin. Yeah.
Please join
All
me.
right.
Thank you
Thank you.
very much.
Thanks.